So, good afternoon everyone. My name is Matthew, and as the title so concisely writes, I'm going to talk about MRI-only proton treatment planning using synthetic CTs for patients diagnosed with glioblastoma. The plan for today is to subject you to a brief introduction to the world of synthetic CTs and how they can be used for treatment planning, while also showcasing some of the work that I've done in my master's thesis. So without further ado, let's get into it. So first I have to thank Andrew Fielding. Because of him, I was lucky enough to spend my summer in Germany studying at the DKFZ, or German Cancer Research Center. While at the DKFZ, I worked under the supervision of Dr. João Secco and his wife, Dr. Maria Francesca Spadida, on the topic of synthetic CTs, also known as pseudo-CTs. Okay, I just want to take a quick moment to say thank you to each of them and the rest of the E041 team for being such gracious hosts and welcoming me to their research family. Really appreciate it. Okay, so now to set the scene for you. We all know that the threat and prevalence rate of cancer is rapidly increasing across the globe. In Australia alone, over 48,500 deaths a year can be attributed to cancer, a pretty big number. The type of cancer we'll be focusing on today is known as glioblastoma. It is a very aggressive form of brain tumor, with a recent population-based study in Ukraine concluding that the median survival rate for diagnosed patients is about 12 months, so it's very aggressive. I've included an MRI of a patient diagnosed with glioblastoma below, and as you can see, the tumor is massive, at least in my opinion. So we have to take steps instantly or as fast as we can to begin treating and hopefully try to improve the quality of life. So a common approach to treatment planning involves obtaining a CT and an MRI scan of a patient and registering the two images. The MR image provides the soft tissue information, which allows for seeing the tumor and just contouring it like we're talking about before, which is shown on your left. And we take the CT, which gives the relative electron density, which can be used to calculate dose, which is on your right. This approach can be problematic as the patient will need to have two scans, and because they're two different scans using two different machines, they'll have different patient setups. So since you have two different patient setups, when you combine the images, you can have alignment issues. So these alignment issues can be between 2 to 5 millimeters, I read, and that can make a big difference, especially when dealing with sensitive organs, such as the nervous system and the brain like we're doing today. Another less pertinent consideration is that CT scans do expose patients to radiation. A study on the subject estimated that 1 in 3,550 20-year-old women who have a regular head CT scan will obtain cancer from that scan. Now these are very small odds, but it's still just something to keep in mind. Okay, so it's not all doom and gloom though. To address these concerns, a potential solution has been put forward, and this is the use of synthetic CTs. So synthetic CTs are a novel approach to treatment planning that involves creating a fake CT from MRI data. Currently, there are 3 approaches to synthetic CT generation, with the first being a voxel-based method. So the voxel-based method utilizes the MRI intensity of each of the patient's image voxels and estimates the corresponding electron densities. In this approach, no information about the location of the voxels is required. Instead, machine learning is used to train the model and predict the Hounsfield numbers. Okay. The next approach, commonly utilized for synthetic CT generation, is an atlas-based approach. So with atlas-based approaches, you do actually need information about the voxel locations. In this approach, the voxel of a patient and MRI are aligned and registered with corresponding voxels in an atlas. The atlas can be generated by one of 3 methods. The first approach is to use a representative patient CT image and registering the patient's of interest MR image to it and obtaining your Hounsfield numbers. The second approach takes the average of multiple sample CTs to form an average reference CT. The third approach is to register the patient's MR images to a previously registered MR image, and since the Hounsfield numbers of the voxels in these atlases are known, an SCT can be generated. The final approach for synthetic CT generation is to combine both the voxel and atlas methods to form a hybrid approach. Unfortunately, an initial study into hybrid approaches found that the addition of doing both the voxel method and the atlas method did not give a better CT than just doing the atlas method. Okay, so what to take from this so far? The aim of this project is to assess the validity of using synthetic CTs instead of just CTs for treatment planning of patients diagnosed with glioblastoma. The benefits of this would include removing registration areas between CTs and MRIs, while also decreasing radiation exposure to patients. In my study here, we used 15 patients diagnosed with glioblastoma with available CTs and MRIs. The synthetic CTs for each of the patients were generated using the German Cancer Research Center's voxel-based approach. And I'm going to gloss over this because I don't understand all the details, but they used a deep convolutional neural network computational method. I've included the generated synthetic CT of a patient on your left and their actual CT on the right, so we have fairly good agreement. Traditionally, where are we? So sorry. Yeah, the reason why this approach has been, why the Germans like this approach so much is because it's been shown to accurately recreate sinus cavities. So traditionally this has been kind of hard because you have the bone high, then you have air cavity which is low, and then you go high again. In one of their studies, they were shown that they could accurately predict and plan while going through the sinus cavity. On top of this, they also found that it had promising results compared to a hybrid-based method out of the Massachusetts General Hospital. So that's another reason why they're very big fans of this method. So now I can finally tell you about some of the work that I did. So the first step in the treatment planning process was to segment each of the tumors. So to do this, I used 3D Slicer, which is an open source software, and I've included a screenshot of the user interface behind me. To segment the tumors, a region around the glioblastoma was roughly highlighted using the segmentation wizard, and this was repeated for every MR slice in the transverse plane. With the tumor roughly selected, the next step was to use thresholding to create an accurate gross tumor volume. As the MRI post-contrast agent caused tumor pixels to light up, this step limited the amount of healthy tissue in the region of interest. Care was also taken to ensure that all the tumor was included in the GTV after thresholding by using the manual segmentation painting tool. The GTV was finally confirmed in the frontal and sagittal planes to ensure accuracy, and this process took a very long time and was repeated for all 15 patients. Next, we actually performed our treatment planning on one of their in-house software things. So MATRAD is an open source radiation treatment planning software created by the DKFZ. It is written in MATLAB and is capable of radiation treatment planning using intensity modulated photons, protons, and carbon ion therapy. There are a lot of options available to users. You can choose how many beams you want, what angles you want, the width of the beams, the number of fractions and your doses, and it even visualizes the dose for you so you can have some idea what's going on. As this study was interested in evaluating the synthetic CT method that they've developed and not optimal tumor coverage, things were kept rather simple. It was assumed that no setup errors would be present, so the planning treatment volume was going to be equivalent to the GTV. A 2-gray proton beam was prescribed at an angle of 0 degrees for all 15 patients, and similarly the gantry was aligned at 0 degrees. The treatment plans were then created for the patient's CTs and synthetic CTs, and the dose profiles of the beams were compared. The dose metric of interest for the study was the proton beam, R80, and range shift. So the range of a proton beam is defined as the point where half of the protons in the beam come to rest, and this point is also equivalent to the depth of the distal 80% dose level. So it is referred to as the R80. The R80 was decided upon as the main focus, as other dose metrics such as gamma tests, dose differences, and dose volume histograms are not as sensitive to proton range shifts. The range shift is defined as the difference between the R80 locations of the synthetic CT and their actual CT. Okay, so for a synthetic CT to be clinically viable, we had to meet these guidelines, which were put forward by the Massachusetts General Hospital and the University of Florida Proton Therapy Institute. These guidelines were that the range shift have to be less than 3.5% of the R80 of the CT, plus 1 millimeter, or less than 2.5% of the R80 CT, plus 1.5 millimeters. The overarching requirement was that 50% of the RS values in a beam had to be smaller than these range requirements, and if that was met, the beam was considered successful and clinically viable. And here was the analysis of the results. So we have a histogram here of all the range shifts that we received for all 150, sorry, I missed the key thing. So there's 15 patients. To keep things simpler, it was decided upon taking 10 central slices. So since we had 15 patients, 10 central slices, we had 150 results. The main thing to take from this is, if there's a range shift of above 5 millimeters, it fails to meet the clinical guidelines. And we had 5 slices that did this. But of these 5 slices, they were only from 3 beams, which meant that over 50% of the beam passed the guidelines, so all the beams were considered clinically viable. And I think the explanation given to why they failed was that the slices that these failures happened in were distal to the isocenter of the beam, so they're more sensitive to range shifts. Okay, we can also check out our dose profiles for the synthetic CT and the CT. So on this graph, we have our synthetic CT in the blue, and we have our actual CT in the red. We can see for the solid line, which shows the dose, there's a very close mirroring, where before we have a slight underestimation of the dose or underdosing, and at the very end we have an overdosing. A similar thing is present for the Hounsfield numbers, which are the dotted lines. They mirror each other closely until we reach our big peak here, which is when we actually get into the bone, and we can see that we underestimate the Hounsfield numbers. So that's something that also needs to be improved to get closer to the actual CT values. Okay, awesome. But we should also keep in mind that there are some caveats with this research. The whole point of this research was to test the German SCT method, not to have optimal patient coverage of the tumors. And so this is especially obvious when looking at the visualization of the dose. Okay, not only is the GTV underdosed, because we were applying 2 gray, and we're only getting 1 gray here, but the healthy tissue in front of the tumor is exposed to unnecessary amounts of radiation. The current treatment orientation would also expose the radiosensitive organs, such as the eyes, to comparable levels of dose as the GTV. In future research has suggested that treatment plans are created with the focus of optimal target coverage instead of just seeing, does it work? And this is actually indeed what is happening. So there's actually another student over in Germany right now. His name is Patrick, and his job is to build on this, taking over the reins, and trying to have optimal tumor coverage. So watch the space. So the summary pretty much is that we had agreement between the SCTs and CTs, and we met the clinical guidelines put forward by Massachusetts and Florida, which is what the previous studies that have been done in Germany were comparing against. And additional benefits of this approach means eliminating the need for CT co-registration, which means no errors introduced while registering the 2 images. We have better patient outcomes due to removal of CT scans, even though it's a small amount of radiation. It's still something to think about. And we also simplify the clinical workflow by reducing workload and costs, apparently, to that study down there. So, thank you for listening.